Okay, welcome back. We're now moving to panel 3, which is a great transition out of the visioning discussion, which talked about a lot of the priorities and critical prerogatives that we want to see operationalized and manifested with these settlement funds and distributions. But of course, as so many have said all day, one size doesn't fit all, which of course is not unexpected for a nationwide epidemic. And this panel is really devoted to diving into and exploring and discussing the various issues that arise when trying to take litigation, bellwethers, et cetera, bankruptcies, all centered on the same fundamental crisis, but whose distribution and management is going to affect the lives of very heterogeneous populations with very heterogeneous needs. Beth Connolly is going to be moderating this panel. She's the project director at the Pew Charitable Trusts and one of the people who's been so instrumental in putting this conference together. Our panelists, I'm sure Beth will say a little bit more about them. Zachary Talbott, he's president and chairman of the National Alliance for Medicaid Assistance Recovery and president of Talbott Legacy Centers, where I'm from in Maryville, Tennessee, and as a personal note, a dear, dear friend. We're so thrilled to have Dr. Edwin Chapman. He's a member of the National Academy of Medicine Committee on Examination of the Integration of Opioid and Infectious Diseases Prevention Efforts. He's a professor at Howard University School of Pharmacy and the College of Medicine. We also have José Esquibel, who's the Associate Director of the Colorado Consortium for Prescription Drug Abuse Prevention. It'll be great to hear from him again. And then a slight change from the program, but a very welcome one. Ariela Migdal is of Counsel at Kellogg, Hansen, Todd, Figel, and Frederick. In the speaker list, you'll see that David Frederick was originally slated to speak. He has a Supreme Court argument, but Ariela works very closely with him, especially with the efforts in Florida. So with that said, I will turn it over to Beth for this very exciting panel.
Oh, thank you so much, Professor Glover. And yeah, really, it was such, the visioning session was really great. I took so many notes. And I really think it does transition very nicely into the discussion that we're about to have. So again, I'm Beth Connolly, and I direct the Substance Use Prevention and Treatment Initiative for the Pew Charitable Trust. And prior to that, I was the Commissioner of Human Services for the state of New Jersey. So all the topics that we're talking about today really fell under my purview. So I feel like this is great discussion for me with my, my Pew national hat on, but also hearkening back to my time in state government. So I'm really excited and really honored to be with all of you today. My colleague, Alexandra Duncan, who you heard from Dr. Duncan before, she always says that every state is a snowflake. And as a former state official, I really couldn't agree more. But we do know that there are some really fundamental actions and considerations that every state should have in mind when designing and distributing the settlement funds. So we have a really great group here today who will be discussing exactly that. And I'd like to start it out asking José Esquibel if he would start talking about states from a big perspective about planning and where states should really be putting their foot in the ground and starting off, if you will.
Great, thank you so much. Pleased to be here, and thank you so much for the invitation. Just making sure that people can see this slide. Does that come up on the screen yet? Wonderful. So my name is José Esquibel, and I serve as director of the Colorado Consortium for Prescription Drug Abuse Prevention, associate director of a Center for Prescription Drug Abuse Prevention. The consortium is the community engagement arm of that particular center. Prior to coming on board as director in about April of 2019, I was an appointee of two attorney generals, Attorney General Kaufman and Attorney General Weiser, serving as director of the Office of Community Engagement in our Colorado Attorney General's office. And one of my roles was advising the attorney generals on the opioid crisis, the issues related to the crisis, visiting communities across the state with the attorney generals to get a finger on the pulse of what's going on in terms of both the impact as well as the responses. And then also advising in terms of where we were going to go in our state with litigation. Back in 2000, I served in that capacity from 2015 to 19. Back in 2016, I was faculty with the National Association of Attorney Generals Training and Research Institute, the NAGTRI group, and I was part of the faculty of the first team that trained attorneys from AG's offices across the state in preparation for the litigations, and then have advised in that regard. So what I'm going to share with you here is a little bit about what we're doing here in Colorado as an example in terms of that state local government collaboration, which is so critical. And my heart goes out to you, Brandon, in terms of where things were on a good roll, and then you see how politically things can dissolve very quickly. So I'm not going to take it for granted. As much as I'm optimistic about what we're doing here in Colorado, always know that things can take a bit of a different turn. But I have to say there are 5 main components here in this example of key partners that have really helped strengthen the state local government collaboration in preparation for the use of the settlement funds. And that is the Attorney General's Office, the Consortium, which has been around since 2013, Colorado Counties, Inc., the Colorado Municipal League, and some really key legislative advocates. I'm going to walk you through kind of what we're setting up here in Colorado to move forward towards the preparation to work at the local level with the utilization of these funds. And so let's see if this will advance. I'm not sure if my slide is going to advance now. Okay, there we go. So right here, this consortium, I was part of the group that initially worked on this. This came out of some work that Governor Hickenlooper back in 2010, Governor Bentley from Alabama, they co-chaired a policy academy on opioids out of the National Association of Governors. And when Hickenlooper chaired this particular policy academy and came back to the state, he asked us in Colorado through a particular group known as the Substance Use Trend and Response Task Force to work together on a state plan to address the prescription drug abuse problem at that point. And that created something called the Consortium. In the early days of the Consortium in 2013, we had about 6 working groups, bringing people from diverse disciplines, state government, non-state government, the medical society, the pharmacist society, the public health workers, law enforcement, you name it, people with lived experience, all coming together to help form this very large consortium of about 800 members, in which we've grown now from a staff of 1.5 to about a staff of 12. And from about 6 working groups now to about 12. Knowing that all of us in these different disciplines were being impacted by opioids and had different strategies, we still needed to coordinate this. And the consortium became that backbone organization to help support that coordinating effort. Again, with the wind in our sails coming not only from Governor Hickenlooper, but at that time, Attorney General Suthers, who gave $1 million to help kick this thing off. And as you can see here, that we are housed in the University of Colorado in the Skaggs School of Pharmacy, and that's the coordinating body. And I'm not going to read through this, but each of these working groups has a combination of state and non-state people working on different aspects of opioid response. And of course, we're grateful to SAMHSA and other folks, John Hopkins and others who have led the way in terms of informing us about evidence-based strategies, that we use this format for getting those strategies, educating our workforce and moving strategies throughout our system. But we made a conscious effort to connect this group as a committee to our state substance abuse trend and response task force that's chaired by the Attorney General. This is a statutory group that has a combination of legislators as well as non-legislators, people and experts in different fields addressing addictions in general. And it was really important for us to connect this here because that particular task force, not only does it look at data and trends in substance use in general, but also advances evidence-based practices, promotes us in the state, but most importantly, submits policy recommendations to the legislature. And so this work group continues to move forward today in our work in advancing both policy and practice in Colorado in response. And this was really the group that helped us prepare and start thinking about planning for opioid settlement funds. And because of the role that I had in the AG's office and some of the work we were doing, I was in a position to see down the road about what was coming down the road and what do we need in our state to prepare for when those dollars come into our state. The consortium has grown to also include staff that live and work in the different regions of the state. And the staff that I have here out there, they work with those local coalitions that I mentioned earlier, some of the rural opioid response grants, the recipients of the SOR grant funding, folks that are getting funding from different sources. We provide technical assistance to those local folks, but it also helps get a finger on the pulse of what people are doing to implement strategies to mitigate the opioid crisis, what their needs are, what their challenges are, what their gaps are, and what we can do to connect them to both state and federal resources as we move along. So we have a rather robust coordinating body, which has been a real positive. Now, I know that other states have had these bodies that have waned or waxed, they've gone away. Indiana used to have a great body out there. Worked with some of your colleagues out that way. But again, a lot of that is dependent on the wins and the sales from political leaders. And we've been very fortunate to have some really good political champions in our state. In particular, back in 2017, there was the beginning of an opioid and other substance use disorder study committee, and very fortunate to have some really key legislators like Senator Brittany Pedersen, Representative Chris Kennedy, and others who really wanted to work closely with us through that substance use trend response task force with the AG's office to look at policy that needed to be put in place to not only prove how we're responding to addictions in general, but also the opioid crisis. But we had in mind, what do we need to do to put in place to prepare for the use of opioid funds over a long period of time? What policies need to be there to help facilitate the use of naloxone, recovery support services, expansion of MAT, harm reduction, other harm reduction strategies, syringe access programs, et cetera. So we had the opportunity to look at policies to pave the way for the work we're doing here in Colorado. Now, back in 2018, some of you may remember this, but Josh Katz with the New York Times Upshot pulled together a large group of professionals from the national level and put a survey out to them and asked them how they would spend $100 billion to solve the opioid crisis. If you didn't see this, do a little Google on this one or just look it up. And it was really quite interesting because when they did the survey, they came up with a bit of a map here that said, look, this is how we from all these different disciplines, a sheriff and a public health person and others would make use of these funds. So there was already starting to be out into the media anyway, be prepared, dollars are coming, start thinking. So I reached out to Josh Katz and said, look, I'd love to know how you did this. What did your survey look like? He led me to Dan Cicerone out of Stanford. We worked with them to revamp their survey. And back in 2019, we began to think about how do we prepare our elected officials for thinking about these settlement funds coming to Colorado. And we pulled together representatives from the AG's office, Colorado Counties, Inc., the Municipal League, our medical society, and this chapter of American College of Emergency Physicians to start thinking about how we would adapt that survey. And in that process, we brought together a small group of about maybe 20 people from different disciplines to take a survey to say, in Colorado, if we had $100 million, what would you recommend the dollars be spent on? And really the intent of this planning, and this was released in December 2019, was a tool for two purposes. One, begin educating elected officials that these funds are coming, here's what's happening, and here's the potential ways that these dollars could be used. Because quite frankly, folks, we have a nice set of parameters of evidence-based approaches. We have a landscape that says, here are strategies that we know work to abate this crisis. We know, and we've heard people say, we're just not moving as fast as the opioid crisis is. We're not implementing them quick enough, and we don't have enough resources to make that difference. So this particular piece, once we did the survey, we did our own little mapping here to say, look, these are what these professionals would say in Colorado, we would want to make these dollars go to X, Y, and Z. But this particular document also had a survey in it that could be adapted at the local level, that local folks could begin doing their local planning, because we weren't presuming that this would be the way that the dollars would actually get used at the local level. It was just a way to start educating folks. And so I could tell you that this particular tool has been used at the local level. And I do believe that one of the judicial districts on the Eastern Coast took this particular example and put out a survey across multiple states on the Eastern Coast as well to do that planning. Now, about a little bit over a year and a half ago, then in early 2020, this work that we did with the Municipal League and the Colorado Counties, Inc., who are actually members of that state substance use trend response task force, they began to convene together a working group of about 40 elected officials to start thinking about how they could start negotiating with the AG's office on the distribution of funds. And I could tell you about a year ago, the proposal in the state from the Attorney General was that 15% would go to the state, 15% to counties, and then 70% to an abatement fund. Well, I have to say that the local folks were not in agreement with that. And I'm really pleased to say that where we ended up just this last month in an MOU that the Attorney General has signed is through this process of which government officials negotiated with the AG, came up with an agreement for almost 90% of these dollars to go out to local folks, 20% directly to local governments, 60% to regions, 10% for infrastructure to help local folks, and only 10% into the state coffers. Now, as a reminder, I mentioned earlier in the discussion that the funds in Colorado will not go to the legislature. They will go into a custodial fund that's overseen by the Attorney General. And that was the purpose of some legislation that we passed several years ago to ensure that these dollars wouldn't get absorbed into the general fund. But I have to give a lot of credit to our local elected officials, College Counties Inc., College Municipal League, when they pulled together their champions to start thinking about what they would want to see for a distribution plan. They came up with 3 goals. They wanted local governments to speak with a unified voice when they negotiated with the AG's office. They wanted to secure all the funding to which Colorado would be eligible by reaching consensus between state and local government. And they wanted to make sure that funds get to the places where it's needed the most. And so much credit goes to these folks, because I'm pretty optimistic that we're going to get nearly just all our governments to sign on here in the next several months to the current agreement that we have here. And that is optimistic, but you never know where the political winds go. So I'll hold my breath a little bit until January and we see where we stand. In that respect, then, we are setting up a system in Colorado with these 19 regions. The Attorney General originally wanted only 5 or 6, but in negotiating with the counties, they really wanted to see where they could work best with counties that they normally have relationships with in other types of use of dollars, and came up with these 19 regions. Now, I have staff in the consortium that are out there working in these regions with these folks. They're helping to set up these regions in terms of their governance structures. They're helping to advise county commissioners and local municipal leaders in terms of what's already happening on the ground, so they become aware of the current work that's going on, so that they can maybe support that current work. And we're in the early processes right now of several of these groups setting up their governance structures, even in advance of the final MOUs signed by all the different counties. And I just can't say enough about the work that we've done and been able to do in Colorado. And a lot of credit goes to Attorney General Weiser for being willing to listen to the county folks, to respect their input on this, and to come to this agreement in terms of the use of the dollars. The other aspect to this, in addition to having signed an MOU that agrees to the percentages of the allocation, is we have a opioid response plan that came out of the AG's office that outlines the allowable uses of settlement funds. So although we don't have in statute yet, we don't have this in statute that says the funds must be used this way, we do have an advisory council that will advise the AG's office that has people from different disciplines, including lived experience. But this particular plan, I think if folks, we can maybe even get this to you down the road, could potentially serve as an example for other states or other legislators, because this gives then a nice, really big, long list of allowable uses. Much of it follows what's in the agreement already with the different distributors and Johnson & Johnson. But we know that the dollars, the majority of our hope then is the majority of the dollars are going to go to this particular mitigation of the opioid crisis. In addition to these strategies you see here, we are focusing on extra efforts to help the rural communities in Colorado that are struggling the most, where we see some of the highest rates of drug overdose deaths. And I'll conclude with these considerations. Some have come up in earlier discussions. We do have to give consideration in Colorado to the data collection. How are we going to determine that we're being effective? So that's still some work to be done. Right now, even now, we're having discussions with local elected officials about leveraging settlement funds with other state, federal, private dollars. There will never be enough with these settlement funds. So what are the other sources that we have to help people allocate? We do have a grant writing assistance program through the consortium where we hire grant writers to help folks mainly in the frontier rural areas who don't have these kind of experts or dollars to hire grant writers. And we've had a really good success, having spent about $353,000 on grant writing. We've helped them secure about 13.5 million. That's about right. $13.5 million. And then the other thing I really want to recommend to everyone, it's time to really, if you haven't done it, review and update state statutes that help facilitate the better use of these settlement funds. And again, I think one of the best places to do some of this work, besides what LAPA is doing, is to do some work with the National Conference of State Legislators. So with that, I'm concluded. I'll stop sharing.
Oh, thank you. That was really great. And I really want to amplify your point about champions. Pew's work in states and my work in state government, really finding that champion or champions is so important to really moving this kind of work forward, because we know as this is Acting Director LaBelle mentioned, stigma is rife in all of this work. And so these champions really can be a voice and really echo and support everything that we're trying to do. I'm really appreciative that one of your slides, your second to last slide, was talking about allowable use because our next two panelists will really chime in exactly on those areas. So first, Dr. Chapman, if you could sort of pick up that thread and talk to us about evidence-based uses for the funding and actually access for the broad populations.
Is on mute?
I'm going to share my screen.
Yes, great.
Can you see my slides? So we know what works. And if we look to Europe, we can see that about 20 years ago, France and Portugal were in the same place that we were. France used buprenorphine treatment. Portugal used methadone treatment. But instead of taking a criminal justice approach, they used a medical approach. And this is what we found. There was an immediate drop in overdose deaths. You can see across the screen. There was also a marked decrease in HIV transmission. But we can see that France and Portugal have the lowest per capita or death rates. The United States had about 320 deaths per 100,000 at the time of this slide. So we can see that their approach worked. We also see on the left-hand side criminal activity and the dramatic drop in 6 locations with medication-assisted treatment or medication for opioid use disorder. So this is our healthcare system. We know that it's siloed, that drug treatment, mental health treatment, and mainstream medical treatment are all separated. We also know that there are differences in funding, payers, regulators. Each state has their own set of regulations, locations where providers are in a state, the providers themselves, and the patients. So this makes for a system really of a structural incompetence. So I was a member of the consensus panel, Opportunities to Improve Opioid Use Disorder and Infectious Diseases, really headed by infectious disease specialists, because they realized that unless they could get a handle on opioid treatment, that they would be unable to control AIDS and hepatitis C, endocarditis in their population. So this was headed by Dr. Carlos Del Rio, chaired from Emory, and we can see 9 issues or barriers that we indicated, starting with prior authorizations for medication for opioid use disorder, data collection, lack of data integration, the fact that patients, we had patients who really could not, or providers who would not treat because they had to get special training. We also have an inadequate workforce. We talked about stigma, payment limitations, and same-day billing restrictions for a medical visit and a psychiatric visit. And then, of course, harm reduction and the disconnect with the criminal justice system. So this is a profile of my patient population here in Washington, D.C. This was taken about 5 years ago, showing that the average age was 52, 2/3 were males, average years incarcerated 10, greater than 50% required mental health medications. 10 to 12% of my patients were already HIV positive, and 60 to 65% hepatitis C positive, 90% smoke, and of course, homelessness was a tremendous problem. So we know the story of by Michelle Alexander, The New Jim Crow, talking about how incarceration, especially in the African-American community, was treatment. So when we look at this incarceration model, and really it's a cycle of despair. All of these various issues, media bias, stigma from the faith community, stigma from the medical community, community, family ostracism, government pushback, all contributed to this failure. So what we wanted to do is change this to a cycle of repair. And we know what we need. We need to bring patients into medical treatment. And that entails everybody from post-hospitalization overdoses, self-referral, post-incarceration, and of course, the homeless, all need to be treated. So this is really starting with a profile of what insurance actually is. It's more than just having the ability to pay. And this was an outline that Dr. Lawrence Gostin from the O'Neill Institute reported in JAMA several years ago, that insurance coverage should not require work or community service. We need to have it located in the neighborhood. It has to be accessible. It has to be affordable. It has to be high quality, cost effective, and of course, education, transportation, infrastructure are all part of this structural competency. And we now know that 80 to 90% of health outcomes are related to what happens in the community outside of the doctor's office and the hospital. So here we're looking at the current homeless situation here in the District of Columbia. So we have to start looking at housing as medicine, as just like having a pill. It really reduces stress and it really makes things 50 to 100% easier to accomplish. We also can see in this slide that if a patient has a mental health problem, the cost of care for any chronic disease doubles. If they have a substance abuse problem, it doubles. But if they have both, it quadruples, as you can see in the red bars to the right. We have a provider deficit, especially in the African-American community. So when we look at the opioid epidemic, we can actually see that we've had two epidemics. We're talking now about the suburban and rural epidemic, which started with pills, transitioned again to street heroin, but quickly transitioned to fentanyl on the right-hand side. The African-American community was always primarily affected by street drugs. So heroin, our epidemic started with heroin, but transitioned in about 2014, 2015 to fentanyl. And of course, we know that fentanyl is 50 to 100 times more potent than morphine. And this is just a batch of fake Percocet pills confiscated by the Drug Enforcement Administration to show you that how the drug cartels have rapidly changed the way they do business. So they're putting these pills out all over the country. This is actually what killed Prince. So here in the District of Columbia in 2015, we had 20% fentanyl in our drug supply. It's now 94%. We can see the dramatic increase from 2018 to 2019 in overdoses, and of course 2020 with COVID on top of it. So this is now transitioned to the rest of the country, and the darker red or brown states actually show that over 50% of the overdose deaths are now due to fentanyl. So we use 3 medications, as you know, for treatment. Naltrexone, which is an antagonist, an injectable, it comes in an injectable form called Vivitrol, methadone, which has been around for 60 years, and of course, buprenorphine. But the problem we have with buprenorphine, if you look at the circled areas, you can see that depending from state to state and plan to plan, the maximum doses allowed vary from 8 milligrams all the way up to 32 milligrams. So if you could imagine a diabetic being in a state where there was a cap on the amount of insulin that could be prescribed to that patient, that's what we're faced with. There's no standard of care. So this is a study that we did about 3 or 4 years ago through the School of Pharmacy at Howard University, and we saw that our patients actually did better with higher doses of buprenorphine, 24 to 32 milligrams. It decreased cravings, negative urines, and retention and care. This was also pointed out in a state study on Medicaid in Vermont, where they found that higher doses of buprenorphine were more effective. So is this epigenetic or genetic? We don't know. But what we do know is that this corresponds to the increase in fentanyl in our drug supply. And in New Jersey, Dr. Rittman mentioned earlier about a study, a project at Rutgers showing, again, higher dosages of buprenorphine in the state of New Jersey now as the standard of care, up to 32 milligrams. And in New Jersey, they're also eliminating prior authorizations and using peer support services, which are very important. So how do we change adverse outcomes? Well, there are 2 components to this. There's the medical component and the non-medical component. And our goals and objectives are to identify treatment barriers to care, identify potential treatment and payment solutions, and achieve the so-called triple aim or quadruple aim if you talk about provider satisfaction, which is extremely important in this treatment milieu. So we want to improve patient satisfaction, improve medical and non-medical outcomes, reduce medical and community impact costs, and improve both patient and provider satisfaction. So in 2018, the American Society of Addiction Medicine and the American Medical Association came together and actually created a template for treatment and payment system. And that was really a coordinated care delivery system or integrated care delivery system, meaning that they realized that all of these services needed to be coalesced either in the same location or with some type of cooperative collaboration with others in the community. But what we have now is the typical MCO that's only focused on cost or cost savings, but that does not really entail appropriate reimbursement, the coordinated care needs, and the quality payment or value-based payments that are required. So ASAM contrasted their approach with the typical EMS or payment system that we typically use evaluation and management for payment. And you can see that based on their findings that there was insufficient or limited insurance coverage for treating substance abuse, a shortage of physicians qualified to provide MAT or MOUD, and lack of access to addiction specialists, in addition to the fact that the payment system just did not meet the cost needed. And what we know with most methadone clinics and buprenorphine treatment, that the payments that are received are anywhere from a third to a half of what is actually needed to properly treat these patients. So this is a model that we created at Howard University about 7 years ago when I transitioned my office from paper records to electronic medical records. We put in telehealth, which at that time was considered not really focused in an urban setting. But we knew that our patients had the same problems that patients in the rural and suburban areas in terms of transportation, babysitting, and other services that are needed. So not being a psychiatrist and being an internist, I knew that my patients needed psychiatric evaluation. But we also knew that 80% of the time that if you give that patient a paper referral, they're not going to go. So the design of this was to capture all of those services when that patient comes in for their medication-assisted prescription. And we coalesce all of the things that you saw above: mental health, social service needs, peer coaching for those who have been in the criminal justice system, and psychiatry. And we compared the two. And the CMS model basically does not incorporate the social determinants of health, whereas the P-code system incorporates social determinants of health and advanced payment for the associated personnel. The CMS system is based on time spent, which does not always and frequently does not correlate with outcomes. So when we look at the high price of the opioid crisis, this came out of a Pew report that showed that when you combine the cost of healthcare costs, the $14 billion in criminal costs, and $92 billion in lost productivity, we can actually add that up. It comes to $141 billion in costs for 2.1 million patients, which equals about $44,000 per year per patient untreated. The Federal Register put out a report in November of 2020 showing that 42 to 44,000 in untreated costs could actually, treatment actually cost about $7,500. So we can see the dramatic savings. So when we put that into a diagram, we can see that with my 250 patients, that if we had close to $2 million to cover all of those services, that we could actually save $7 million in annual criminal costs. But these are wrong pocket savings. We could also save about $8.5 million in per annum tertiary medical costs, infectious diseases, hospitalizations for uncontrolled hypertension, diabetes, et cetera, and also may save money on lost productivity. But these wrong pocket savings do not accrue to the insurance company. So what this tells us is that every dollar spent on substance abuse treatment saves $7 or more. And when we look back, we can actually account for these savings first in opioid treatment itself and measure it through retention and care, negative opioid toxicology, decreased overdose, emergency room and hospital visits, as well as deaths. But we can also measure regular medical outcomes, decreases in blood pressure control, hemoglobin A1Cs, viral loads. It also gives us access to patients for preventive services like colonoscopies, mammograms, prostate examinations, as well as all of the other medical and mental health services that we previously talked about. So surprisingly, I got this email just on Monday from Sandy Marks from the AMA, who actually worked as part of the team of the AMA and ASAM in putting PICO together. And she indicated in their survey, not one state or one health plan has incorporated the P-code system for treatment, even though this was put together by the top experts in opioid treatment in the country. So now where are we? We are at a point where there's talk of retreating on telehealth. And we know that telehealth saved many practices. And this is again from a report from George Washington University that shows what the government did in stepping in to allow televisits that kept many patients and practices afloat. So in summary, we have to really create structural competence. And that means medical treatment over incarceration, harm reduction that's been talked about, maximize technical access using telehealth, look closely at our dosing now that this epidemic has changed to a fentanyl epidemic, provide universal housing as a medical necessity, incorporate the P-code system, and extend telehealth in perpetuity. So this was a meeting that I was fortunate enough to have with Congressman Elijah Cummings just 3 months before his untimely passing, with members of the National Medical Association and the auxiliary to the National Medical Association. And I'll never forget, he said, "I love research, but not research that sits on a shelf." So we have to take what we know and begin to apply it. And we know how to fix this. I'm going to stop there.
Thank you so much. That was really filled with so much for states to consider as they think about using these opioid funds and really designing them. Thanks for so much data, especially understanding the composition of Washington, D.C. And how things other states should really keep in mind as they move forward. So building on Dr. Chapman, Zach, would you kind of talk to us a little bit about as we look at the opioid settlement dollars and thinking about continuum of care, and what are the other things that states and localities should really be thinking about plugging in as they're designing their expenditures?
Sure, thanks, Beth. I just want to say thanks to Professor Glover and Georgetown, O'Neill, and Pew for making this happen today. It's been a great meeting thus far. My name is Zach. I'm as Maria mentioned earlier, or Professor Glover rather, the president of National Alliance for Medication Assisted Recovery, or NAMA Recovery, as some folks know it, which is the oldest and largest advocacy organization specifically focused on the rights and voices of individuals in medication-supported recovery from opioid use disorder. We're the only organization that mandates by our bylaws a majority of directors be in recovery because of from opioid use disorder. And so I speak to you today here to give my perspective, but also on behalf of the individuals across our country who are seeking care and or are in recovery from opioid use disorder. So there's a lot. I'm going to try to be concise as I'm able and talk a little bit today about comprehensive care, about recovery support, and build on some of the good data that Dr. Chapman gave us and what that looks like on the ground as an individual in long-term recovery myself, but also as a treatment provider. So I sort of straddle that fence, and we'll try to bring some of some of that data, build on some of that for you. Some things that are really important is as we think about how we put standards in place or operationalize the settlement money, is that we focus on ensuring that there's access to all FDA-approved medications, not just one or two, but all three for opioid use disorders, in systems where individuals have access to comprehensive psychosocial and recovery support services. Dr. Chapman had mentioned, you know, there's the integrated versus coordinated care. So there's different ways to accomplish that, but access is what matters, and access in a way that we don't force individuals into services they don't need or want, which has also become a problem in some other places. So how do we expand access to all three medications? It's worth noting for those of you, I don't want to take anything for granted, something that's important to consider as the states look at this and we look at ways to operationalize the money, is that the only federally certified, they're known as opioid treatment programs or OTPs, are the only entities currently that can offer all three FDA-approved medications for opioid use disorder. So they're also the only programs that are regulatorily guaranteed or required to do integrated comprehensive services. We have a lot of office-based physicians that are prescribing waiver to prescribe buprenorphine products, as well as using naltrexone, extended release injectable naltrexone. But as Dr. Chapman highlighted, there's funding needs there. Physician offices, traditional medical offices aren't typically built to accommodate that staff. And so funding and workforce development issues are important as whether we do integrated, comprehensive, or coordinated comprehensive care in our office-based models. OTPs are also, opioid treatment programs, the only outpatient MOUD providers. This is something that patients often feel is important, with a federal mandate to be accredited by a deemed accreditor, which ensures certain quality guardrails that protects patients, and it guarantees basic outcome measures as well. Outpatient and residential programs both can become certified OTPs. A lot of people think of those more traditionally as we've known methadone clinics, which was the terminology from the day when methadone was the only medication that was largely utilized. But now we have three. But instead of, they've traditionally been thought of as a level of care or a standalone, and often that's true, but they can be incorporated into residential programs. There can be incorporated into hospitals. We should look at certified community mental health centers and to start thinking that more of a service line, a service division, than a level of care that's separate from the rest. How can we incorporate all three medications there? And when we talk about comprehensive care, a lot of folks will throw data that shows how, when you look at overdose and survival, individuals that have access to medication and individuals that have access to medication and comprehensive psychosocial and recovery support services have similar outcomes when it comes to overdose decrease and survival, and that's true. But the short side there that I think it's critical for us to remember is that the majority of patients, a recent study showed 80.1% that enrolled in treatment for opioid use disorder had experienced significant trauma. Methadone, buprenorphine, and naltrexone don't treat trauma. And a majority of individuals that have substance use disorders also have some other, to varying degrees, mental disorders, be it depression, be it anxiety, a variety of other things. And so it's important to realize that methadone, buprenorphine, and naltrexone are critical tools, but they don't treat those things. And so that's why it's important patients have access based on their needs to these things. It's also important to remember that with rising tolerances, we've expanded buprenorphine greatly. We've done a great job. There's also been a big expansion of methadone through certified OTPs across the country. But as rising tolerances, Dr. Chapman, the one study about their fentanyl surviving patients, we have higher tolerances, more severe opioid addictions now with the introduction of fentanyl into the heroin supply. I can tell you from one of my treatment programs in Eastern Tennessee, over 50% now of our admissions that report heroin as their only use are now fentanyl only positive when their drug screens return from the lab. About half of those that are positive for actual heroin or opiates also have fentanyl. And so fentanyl's dominating in our experience. Roughly 3/4 of those are either positive for fentanyl only or positive for opiates and fentanyl at admission. And so ensuring access to all three medications, including the full agonist methadone for these higher tolerances and or higher doses of buprenorphine, as Dr. Chapman pointed out, is critical as we move forward. One note on if we talk about model state laws and things that we could do that could have a big impact even within our current regulatory environment is if we considered in a model state law, if we aligned state regulations around opioid treatment, be that opioid treatment programs, which all states have their own regulations for OTPs, and or some states now have regulations and licensing requirements for office-based opioid treatment, such as my home state of Tennessee. You must be licensed as an OBOT now. And so if we could align our state opioid treatment regulations with the federal regulations, it would go a long way, especially in blowing open access to all three meds through OTPs. That's where a lot of the restrictions occur, or through state regs. And reforming federal regulations is something that we should consider on the OTP side. I know there's some talk of that right now with our colleagues at SAMHSA, but and that's good, but it will make no impact in the states unless they also reform their regulations. And that's where some of the most draconian rules are still in place. And so when we think about how do we have to also consider, we talk a lot about rehabilitation historically, but there's a subset of individuals. How do you rehabilitate an individual that has never been habilitated? And so that's why it's so critical that we have access to things like counseling, case management, resources, and recovery support services. We can't put everyone in the same box. And some of these individuals don't have, especially in some of the areas I serve, don't even have some of the most basic skills. And so we can't treat them coming from our worldview of being educated professionals. And so access to recovery support is critical. I know Brandon talked about that some earlier in an earlier panel, but just to build a little bit on what he said, we have to think about recovery support both within, adjacent to, and beyond treatment. So a lot of the current funding through CMS, especially state Medicaid programs, and even some federal grants, although there have been some targeted at recovery community organizations, are restricted to peer recovery services and support within treatment only. And that's important, but we've got to go beyond that. We've got to ensure that money gets to recovery community organizations or RCOs locally, as well as to national organizations like Faces and Voices of Recovery that are really critical in confronting the crisis and supporting new and existing recovery community organizations. It's critical they have access to these funds and recovery residences, but we have to be sure that it's recovery residences that do not discriminate against individuals who are enrolled in medication-assisted treatment or who are currently taking a medication for opioid use disorder. The vast majority of recovery residences in my region will not allow an individual who takes medication for opioid use disorder to enroll. Money should not go to programs that prop up those practices. The structure of how we distribute these funds could go a long way in pushing some of that forward with the purse strings, if you will. A note on harm reduction, we've had a lot of talk of that, and it's critical. Syringe service programs, they're evidence-based, and naloxone, it's evidence-based. But I do want to state on behalf, from the recovery advocacy standpoint, it's critical we continue to focus on harm reduction as an evidence-based practice. What is reducing harm? There has been sort of a subset under that movement that would relegate harm reduction more to just access to drugs or an endorsement of chaotic use. And so to really focus on what the folks today have talked about, when we talk about harm reduction, what are we talking about? What does the evidence show? Things like syringe service programs can be a linkage to care when an individual, if and when they're ready. Then maybe our Medicaid programs or other healthcare costs don't have to bear the burden of HIV treatment, Hep C treatment, et cetera. As Dr. Chapman mentioned, workforce development is critical, especially in rural areas. With all the expansion we've had, it's hard to hire workforce to find people. And so workforce development's important. A lot of the stuff we have now around loan forgiveness, there's a lot of qualifications, a lot of red tape. And so we've got to cut through some of that, because we can expand access all day, we can throw money at it, but if we don't have a workforce to provide it, it will be of little value. And so that's, I think that sums it up, what I wanted to say.
Thank you so much. And again, quite a bit for states to really think about. And I really like your point about where aligning state rules with the federal rules and not exceeding, because states are only creating barriers for people to actually access treatment. So as we talk about planning and as we talk about looking at gaps, this is something states should be really examining. Look at your own regulations, and are they actually creating barriers for people to access treatment, and especially evidence-based treatment. So our last presenter, before we go to questions, is Ariela Migdal, and I'm hoping that you can sort of tie in what our first three panelists from the view of a litigator, but also maybe give us some insight into the view of the judiciary, because that's something we haven't talked about really. We talked about a little bit today, but not from this perspective. So please.
Thank you so much, Beth. And I want to thank the organizers and really the other panelists in this panel and the other ones I've been able to listen to. I feel a little bit like a fish out of water because I've been so focused on the litigation. I represent state governments in their opioid cases, but I'm not speaking on their behalf today. I'm really speaking with my personal hat on as having been in this work now for a number of years. And I learned so much every time I hear those of you engaged in the treatment and in the program. So thank you very much for having me. I guess I wanted to back up, and this conference is about the settlement funds, but it might be helpful for stakeholders to back up and think about what are we settling, and how is it that the litigation or the pre-litigation investigations that gave rise to these settlements shapes what happens with them, and how states and other stakeholders can think about the litigation in relation to how it might end. Settlement is obviously only one way that litigation can end. A lawsuit can also end in a trial, in appeals, in a judgment. And in those instances, what you're going to have is you're going to have judges, and in some cases, juries, determining the outcome. And that can look very different from the settlements that are being discussed. And so I hope it'll be useful to just back up and think about this alternate universe of the litigation, or the pre-universe of the litigation. One thing to think about when states and other government entities bring these cases is that they can seek a number of different kinds of remedies depending on the kinds of claims that they're bringing. And just for these purposes, it might be useful to divide them into the buckets of backward-looking money, in other words, damages that compensate states or cities or other plaintiffs for harms that already happened to them, versus forward-looking relief. And I think much of our discussion today has centered on that forward-looking relief, which I'll get to in a minute. But many of the lawsuits that, around the country seek both. They might seek backward-looking relief, which is the damages to states, to government entities, and in some cases to individual victims. And in those cases, you're going to be talking about paying back for harms that occurred. In the same lawsuit or in different lawsuits, you could also be looking at forward-looking relief. And that's the heart of what these settlements are sort of focused on. In legal terms, that often can be called an abatement remedy or an equitable remedy. And it's sometimes framed in terms of what has to happen in order for the public health crisis to be solved. If the state or city or county has brought a public nuisance claim, for example, the idea is a public health crisis has occurred, has been created by the defendants. What will they have to do in order to clean that up, in order to fix it? And that gives rise to a number of premises that kind of can shape what happens with the remedy and with the with even the settlements. When you're talking about forward-looking relief and you're in court, judges and courts are going to think about what is the time frame you're talking about. Can this crisis be abated? When you're talking about a public nuisance, for example, in many states and jurisdictions, you can have a permanent nuisance or you can have a temporary nuisance that can be abated. The premise of many of these lawsuits is that all of our public health crisis around opioids is a temporary nuisance and it can be abated. That doesn't mean that the people who have died from overdoses can be brought back or that the harms can be undone in that sense. So it's sort of a counterintuitive notion. But the idea is that opioid use disorder can be treated and future instances of opioid use disorder can be screened and eventually prevented through these various interventions. And that notion is, sort of legally something that the courts are going to want to know and ask about. Is this a crisis that can be abated? And also, what is the time frame? Courts are reluctant to take hold and manage something like this forever. They're going to want to know, how long will it take to abate the opioid crisis? And they'll ask that in various ways. And the government plaintiffs have to show that. And there's no one right way to do that. I've seen it done a number of ways. You can have a state put together an abatement plan or abatement recommendations, usually in consultations with experts like yourselves and stakeholders and government workers, healthcare providers, people in recovery. And they may say, this is how much it will cost to do this plan for 20 years, 25 years, or 30 years. They're going to have to convince the courts that it's going to take longer than just a very short time frame. Other states might say some of these interventions might be needed for a shorter period of time, such as certain retraining or educating the prescribing workforce to have a different culture around prescribing prescription opioids. Other interventions might need to be in place for much longer. Tertiary interventions that some of you have discussed, medication-assisted treatment. We know that opioid use disorder for many people will be something that requires lifelong treatment. And yet, as I mentioned, courts are usually not going to want to supervise that indefinitely. So you might see a cap on it. We'll do this for 30 years, or we're going to ask for this remedy for 20, 25, or 30 years, or some other number. And if you look at the bankruptcies and settlements that have been floated, and if you look at state and government abatement plans in the various jurisdictions, they float different numbers. But I would say everybody agrees that this is going to take longer than 5 to 10 years to abate. And I haven't seen plans that try to get a court to supervise this or to order relief that extends past 30 or 35 years. So there's some sort of window, and it's worth thinking about that. Another way that you can think about this is to, there's been a lot of talk about evidence-based strategies. But when you're crafting an abatement remedy from the standpoint of litigation, you want to be able to present that to a court, a jury, or a judge right now or in a year when your trial is. And of course, we don't have full information yet about what works. And so what you'll see in many of these plans, and I think it will happen as well from what I've heard with the settlements, is that you'll build in evaluation and research strategies. You'll say such and such kind of mobile outreach or bridge program in a neonatal unit is promising. We have some evidence to support it. Can we say yet which of these 2 or 3 ways to do the model is the best? Maybe we don't know yet. In some instances, we're doing that research now, and you want to build in to your abatement resources the opportunity to evaluate programs as you go and to make those adjustments so that you're getting the best knowledge even 10 years out, even though your jury trial is next month. The other thing is to figure out the buy-in from stakeholders. And this is where what I have seen in these abatement remedies is that the governments will look at best practices from researchers in the field, like many of you. They'll look at federal guidance. They'll look at their own state's guidance, and many states do have the task forces or working groups, either on opioids specifically or on substance use, drug policy councils, and so on. They'll look at the reports that those entities have issued, and they'll drill down and also look at what works locally. If you have a state with huge rural areas, you're going to be talking to the groups in those areas to figure out what is needed, what works. It's easy to say we're going to need mobile outreach, for example, but how much, how many, where in your state is that needed? Those are going to be tailored by state, and usually building in some flexibility for those factors to change over time. The other thing that states are looking to do is sort of maximize, some of you spoke about this, maximize and build upon what's already out there in their state. So for example, just to use an example that at this point, everybody has a prescription drug monitoring program. You can say this is effective at identifying instances where somebody's attempting to fill prescriptions from multiple doctors or too close together in time. But there's a lot of thinking now from what I've seen out there about how do you take that framework and build upon it so that you're not just using the PDMP to turn people away, but perhaps using it as a bridge or to get them support or connected to peers. So a lot of that thinking goes in. You can't think of everything on the litigation timeframe. And so what states and governments are doing are trying to build in the flexibility to continue to learn as the remedies are implemented. And I think that will be the same with the settlements. And finally, the states and local governments and the different kinds of plaintiffs are looking at each other. There's a lot of litigation around the country in different stages. Some trials have happened, some are scheduled. There's a lot going on with the discovery. And so entities are looking at one another to see what works, what is accepted by courts, what concerns have courts voiced. As we have more trials, we'll see what are the issues that judges and juries are concerned about, what's making them nervous about the proposals, and how can advocates and stakeholders address those if these are really the interventions that we think are needed. So, as the settlement monies come in, there may be a flexibility there that's different from a litigation judgment. You may not have to commit, for example, to this timeframes in the same way, but they're still going to be structured in a judicial fashion and sort of have to be blessed in that sense to some extent by courts. And so these are, I think, worth thinking about, these doctrinal issues. Are you asking for a forward-looking remedy? Does it have an end date? Does it have some flexibility and choices on the time frame in terms of how long you think it needs to go? And can you justify how much you're saying it costs? And then, of course, the last one is these settlements, you're settling cases that are brought against particular defendants and entities. And so judges are going to want to ask, are the things you're asking for addressing harms that these entities caused? It sounds obvious, but it can't, so in that sense, it has to be sort of tied to what the case was about in the first place, which is maybe not a limitation when you're doing policy enactments. You can address every social ill under the sun. Here, I think governments, plaintiffs, states are trying to show everything that we're seeking in this lawsuit is tied to the harms originally caused by these defendants or set off by these defendants. And here's how we're going to show that, and relying on experts like many of you to show those connections. So thank you again for inviting me. It's been incredible to hear the latest state-of-the-art thinking on how all of this will be done.
Thank you so much. And it really did give us a great perspective on how we should start fashioning and thinking about how we as public health professionals want to bring our thoughts to the table in these cases. We have only a couple minutes, but since we have this, we're talking about the thinking about how we were looking at the settlements. And in the visioning panel, one of the participants asked about how do we as public health professionals and as advocates, how do we get the ear of someone like you as the litigator? How do we make our voices heard, and how can we help to influence the thinking?
Well, the litigator is hopefully not some sort of free agent, but they're representing somebody. And I recognize that can get very complicated when they may be representing a huge class of entities or a state, and you're a practitioner in that state. But usually, I mean, I can't speak for how everybody does this, but when you're crafting the abatement remedy as a litigator, you're not working in a vacuum. You're reaching out to the people in the state. They're telling you, the people at the SAMH division within the state are saying, here are who's contracted, here are the doctors who have worked on this. You can just through Google and conversations, look at who are doing the pilot programs in the state. Where is the harm reduction happening? Who has developed a syringe services program and understands how much it costs and how it would work to scale that? And so, the good abatement plans, and I think they're all good, but there's no perfect way to do it. Everybody, I think, is looking at the best research and reaching out to people like you to get the sort of current knowledge. And I think the point has been made a lot about people with lived experience and peers. And so my hope is that all of these plans also reflect that input and not sort of cooked up in a vacuum. And I have confidence that they are, because people are working very hard to make sure these will be feasible, but also feasible, effective, but also effective for the people who will be participating.
Thank you. We are bumping up against our time for the next panel, and so I want to be cognizant of that. We have, I hope our panelists will join us tomorrow, where I'd like to really raise a number of the issues that we talked about around the evidence base and evidence-based practices, and how do we bring those in. So I'd like to really have a full discussion about that. And we touched a little bit about evaluation and research, which is also something I hope that we can delve into a little bit more when Dr. Duncan and I convene with all of you again tomorrow. So thank you to the panelists. It's been really great. And I know you've given lots of thought-provoking ideas to our state participants.
Thank you so much.
Thank you.
Thanks so much, Beth, and thanks so much to the panel. And just to add to what Beth said about some of the things we're talking about tomorrow, I know we ran out of time for Q&A on this panel, but so much of the operationalizing of these priorities is going to involve what I hope will be a pretty in-depth discussion tomorrow about some of the things that came up in this panel. When you have these ideals and you have these priorities, how do they intersect with various laws and regulatory regimes that are maybe not even within the mass settlement context, but within family law, within employment law, where funding for evidence-based treatment might bump up against certain penalties in states and localities for using such treatments? And how do we harmonize the different legal regimes and regulatory regimes for all these priorities? And so, Beth, I'm hoping we can sort of marry a lot of that tomorrow.